This is Busybody Podcast. I'm Cadence Dubious. I'm speaking today with Dr. Alexis Hazen, who is New York City's #1 top surgeon. And so you have your own practice. Did your skincare line come out? That's the other thing I've been following on Instagram. I want to do a whole side thing where we talk about our skin.
Yeah, no, absolutely. We must do that. So it was literally about to launch, and we had, everything was kind of like pretty close to ready to go. And it's a long story, but the short version is I developed all these allergies, and so I went and, sought medical attention and figured out that, it wasn't clear that it was allergies. It was diagnosed as eczema and blah, blah, blah. Anyway, turns out in most products, even if they say they're all natural, there are all these chemicals. Yeah. And it turns out I'm super sensitive to anything that's not actually all natural. So the line that we had sort of developed was extremely clean, but there are preservatives and things that enhance the shelf life, and fragrance is actually a chemical.
Super synthetic.
Yeah. So long story short, we totally revamped the whole line. Well, and cool. Now it's like the minimal ingredients, any aroma comes from totally natural fragrance, like, rosemary or eucalyptus or rose. And so it's now going to be coming out this summer. So
fantastic. Now it has an origin story.
Yeah, totally. So I can even use it. Yeah. And if I can use it, anyone can use it, because I have the most sensitive skin ever. That's I can't put anything on my skin. So
yeah. Fantastic. Well, I think fondly of the time you and I have collaborated quite a bit on a bunch of workshops specifically for people who have had top surgery. And at some point when we were organizing one deep in the pandemic, but when no one could leave the house, we had a little Zoom chat. And then I was like, I'm so sorry. I'm sure people do this all the time. Can I show you a weird skin thing that I have? Because I was like, what if I have skin cancer in the middle of the pandemic?
Yeah. Right. And you can't get to see a doctor. No, I know. Exactly. Yeah. And then you take like you need a close-up shot of it. Yeah.
Exactly.
Absolutely.
Yeah. Fortunately, I was fine.
Yeah. Sidebar consult. I love it.
Well, I wanted to have you on today to discuss a bunch of things, but I thought it would be great to actually just describe what happens in top surgery and if there's a difference versus mastectomy and top surgery, because a lot of people in my community deal with both. And also, as I was saying before we started recording, I think a lot of my work with trans clients is also about just normalizing all of these procedures, all of the things that could potentially be part of being a trans person, and making it so that if it's kind of just more like destigmatized to the point where we don't need to have a separate class specifically for trans people. Someone could just come into any Pilates class and be like, oh, by the way, I had top surgery. Just like I have so many women come to my class and say, oh, by the way, I had breast reconstruction or I had mastectomy. And everyone just goes, oh, okay. And we all know what that is and what that entails and how to deal with that in class, instead of it seeming like it's really a big drama and a big deal.
Yeah. So I think, the biggest sort of it's conceptual difference is the purpose of the surgery. So the purpose of mastectomy for cancer is to eradicate the cancer. And so there's sort of there are three parts to that. It's where the cancer is, and then all the surrounding breast tissue. So for people who aren't a candidate for lumpectomy or who choose to get a mastectomy, they're having all the breast tissue removed, plus wherever the cancer was. So a lot of times the cancer might be close to the skin. So the skin surrounding that will be removed. And in most cases, the nipple and areola have to get removed, because often there are ducts that go through the breast tissue that end up in the nipple areola. So if there is any connection between the cancer and those ducts, you're going to want to remove the nipple and areola. Every now and then for cancer, you can do what's called a nipple sparing mastectomy, but the circumstances have to be very specific and precise. So basically you're removing all the breast tissue and often some of the skin. And then plus minus lymph nodes. So depending on, the level of the cancer, you might do just, what's called a sentinel lymph node, where you're removing one lymph node, or you might be removing many lymph nodes if the concern is that it's kind of infiltrated into the lymph nodes.
And those lymph nodes are around the armpit, just so people know.
Exactly. They go into the armpit and they drain the breast, and then they also help reduce, any kind of drainage into the arm. So that is sort of the mastectomy for cancer story. And then top surgery, it depends who you go to, and a lot of practitioners kind of have different methods for doing it. And a lot of it depends on the size of the chest to start, and the location and size of the nipple and the areola. But primarily, I think of it as a functional operation because it really changes people's lives in a very functional way. But if you're looking at it just from sort of a cosmetic standpoint, you're removing breast tissue, skin, and then reconstructing the nipple and areola, and typically to look either in a very masculine way or in a kind of a non-binary way. And so the skin that you're removing is really just for cosmetic purposes. So you can design the incision, exactly where you want it for cosmetic purposes. And then you would never remove lymph nodes. So those are the big differences. I tend to do what I call a real mastectomy, in that I remove all the breast tissue. Some surgeons leave some breast tissue to kind of contour the chest and make it look like it's the muscle. So, how people who work out a lot have like a big pectoralis muscle. So they might leave some of that. I feel like that's sort of not wise, because then it's very hard to monitor that breast tissue that remains in terms of surveillance for cancer. So those are sort of the big differences. And I think one sort of interesting aspect of it is that, and it hasn't been studied extensively, but the pain following the procedures seems to be different. And people who get top surgery tend to report less pain than people who have a mastectomy for cancer reasons. And I really think it's like attitudinal, in that nobody wants to have a mastectomy for cancer, whereas people choose to have top surgery for, gender affirming purposes. And I think that the perception of pain ends up being different just based on your sort of desire and your, feeling maybe some semblance of control about it.
Yeah, that makes a lot of sense. Plus, I have a client right now who just had a mastectomy, double mastectomy. And like, obviously this whole thing was a surprise. So she hasn't prepared for this.
Yeah.
And then versus when you have top surgery, you are aiming to do this for a long time. You're preparing yourself mentally, emotionally, physically. So the recovery process is going to be, if anything, a relief that this has finally happened instead of just more stress.
Totally. And you probably, and in a lot of cases, hopefully you have sort of a support team that's been, working with you maybe for a while.
Yeah.
I mean, of course, some people don't, but ideally that would be the case.
What's the difference between a masculine and a non-binary nipple? I love that idea.
Yeah. So, the top surgery has evolved in my time doing it. And it was sort of like one stop shop, and everybody kind of described wanting the same thing, which was a quote unquote masculine chest. And then, I think as gender identity has become more nuanced, people have different desires and realize that there are different ways of doing this.
Yeah.
And so if you think of the typical masculine chest, the nipple is is connected or sort of oriented towards the lateral aspect of the pectoralis major muscle. It tends to be low on that muscle and very, very small. And the nipple is very small, about the size of a eraser. And the areola is about the size of a quarter. So some people who identify as non-binary choose to have the nipple and areola a little bit larger and placed in a less typically masculine position. So more in like the center of where the chest mound would be.
Almost like a flat chested woman, basically, like
basically
prepubescent.
Totally. So when someone's developing, like if you took a snapshot of, a typical girl chest, it's sort of like what that looks like.
Interesting.
And it's something I think I didn't invent that. I mean,
right.
I didn't come up with that. Most of anything that's been innovative has been driven by my patients asking for things, and then me being trying to figure out, well, could I do that or could I not, or why couldn't I? And the other sort of, continuum on that is like a radical reduction. So, breast reduction has been in operation for a long time. And a lot of patients who identify as non-binary now seek sort of a radical reduction. So there's still some breast tissue, and it looks like a breast, but like a very, very small breast. So sort of like, as the beginnings of development kind of thing. And that's definitely been driven by patients.
That's so interesting. Is there any benefit or not benefit to any of these options? Like, is there one that's kind of more dangerous or less dangerous, or?
Yeah. I mean, I think they're all extremely safe, which is great. And they are, they've been pretty well studied. I think, anytime you're leaving breast tissue behind, you just have to be cognizant of the fact that breast tissue has to be monitored, just like for every cis woman who has breast tissue, or, or any trans woman who has breast tissue. You need to get mammograms, and it needs to be surveyed after 40 with no risk factors, or 35 with risk factors. But the one real benefit of doing a kind of a radical reduction is that you're leaving breast tissue and nerves connected to the nipple and areola, so you could maintain similar sensation. Most patients do get sensation back to some degree after these surgeries, but it varies a lot and it's unpredictable. So if you are leaving all those things connected, then it's much more reliable in terms of what it feels like. So I would say that's the big benefit. The aftercare, if you're doing top surgery through what's called a double incision, there's a little more aftercare in terms of dressing changes. But basically the recovery is similar in all these operations. And it's sort of like 6 weeks till you're back to, vigorous, heavy lifting. But after 2 weeks, most people can do a lot of things.
That is kind of my next question, because we've talked a lot in workshops that we've done together about mainly scar tissue and pain, and we've never really had a chance to just talk only about those things. That is like the number one question that I get asked all the time is, how soon can I get back to doing something? What are the boundaries? And then there's always this kind of laundry list of really random things that their depending, and I'm talking about like any surgery from like hip replacement to, a cesarean. It's like, they can't lift more than 20 pounds. You can't put your arm over your head. Yeah. You can't do a sit up, but like you can fold laundry, but you can't do this. And it's like, recently, like, you are allowed to do a cat cow, but you can't do, and it's just like, I have a lot of issues with that, because I feel like a lot of doctors they're not physiotherapists. They're not exercise scientists. I had a client who had a appendicitis. Her doctor told her that she could go running, but she couldn't do anything that worked her abdominals. And she said, but running uses your abdominals. And he said, no, it doesn't. It's just your legs. And she was like, that's not how running works. So I'm always very, I try to tell people, obviously you're waiting till you're like not weeping anymore, like till the, things are healed. And then you have to, what's so hard about all these kinds of prescriptive things is really you have to trust yourself, because everybody is different. And I think that a lot of these like 6 weeks until this, 12 weeks until this, is because they're afraid that someone is going to run out of surgery and go take CrossFit or something and just rip all their incisions open and just be a crazy person.
Totally.
So what are your thoughts on recovery in general?
Well, I love this question because I think that most of the recommendations are quite random and not scientifically based, and they're prescriptive in that, you don't want someone hurting themselves. So it's a lot easier to say, don't do these things.
Right.
To, kind of go line item by line item. Well, this is probably okay, but that's not. So I think a lot of doctors, just for simplicity, say, don't do X, Y, Z, or the other things, because that's the easiest way to manage it. So there is some science behind this, in that 6 weeks following surgery in normal healing or an injury, the tensile strength of the wound is as strong as it's ever going to get.
Oh, wow.
So 6 weeks for me is sort of, if someone has normal healing and there's no infection, there's no wound breakdown, whatever, at 6 weeks, they should be able to do anything that they're ever going to be able to do, because that's normal healing. That doesn't mean that couldn't impair their scarring. And, so then that's sort of another topic, but in terms of healing, it should be fine. Mm-hmm. So then, in terms of very specific things, there's not that much research on, 5 pounds, 10 pounds, 20 pounds, like when can you lift those things? So it really is quite arbitrary. But what we do know is that exertion and getting your blood pressure up can cause bleeding, and that the risk of bleeding is the most high in the 24 hours following surgery. But it exists for about 2 weeks. Mm-hmm. And so because there's all these raw surfaces that have, little clots have formed on them, you really don't want someone really exerting themselves for the first 2 weeks after surgery. So things like heavy lifting, but also like bearing down and making a bowel movement.
Right.
Like that can send your blood pressure. Having vigorous sex, like there are a lot of things that can send your blood pressure up, and they can cause bleeding. So you really don't want to do that. I'm thinking
of how many clients I've had who have had bleeding after cesareans or birth, because you are now a mom. And so you can't just lay around. And so they're like, I was like holding my toddler, bringing them up the stairs while I'm also holding the newborn. And all of a sudden my incisions start bleeding and like all this stuff. It's like, because you just lifted like 45 pounds upstairs of a wriggling human.
100%. So that's like real and scientific. And then I really think the rest of it becomes sort of arbitrary. Right. Because to really make scientific decisions, you need randomized controlled studies looking at different aspects. But what I can tell you is there was recently a study that looked at women who had breast augmentation with silicone implants, and they had 2 different cohorts. One cohort, they allowed to do whatever they wanted to, vigorous activity, stretching, weightlifting, running. And the other one, they restricted their activity aggressively, and they weren't allowed to, use their arms past a certain, angle. They couldn't lift weights. And the group that had no restrictions took less pain meds, had better range of motion, recovered faster, and felt better. So I think in general, I think restrictions on movement, if the movement is not sort of rapid. So, using your arm to stretch over your head after a mastectomy, I think that's got to be fine. Mm-hmm. I think that the problem with heavy lifting is not so much, it's the strain on the muscle a little bit, but really it's the change in your blood pressure, which could then cause, a blood vessel to burst open and bleeding. And I think that, for some operations, like you mentioned, a hip replacement, you want to get the joint moving immediately, and they encourage full weight bearing, depending on where the incision is, and ambulating like every 2 hours.
Yeah.
And that really helps with range of motion. So especially in older patients, I think getting your joints moving quickly is really important. So for women who have cancer, who undergo mastectomies, who are older, I think doing range of motion and stretching their arm and getting their shoulder moving is really important after that surgery, because it's so easy to develop a frozen shoulder or that kind of thing. Mm-hmm. And I think one of the things both you and I have realized is that a lot of the pain that people experience post-surgery is this fascial contracture and scar tissue formation. And so to the extent that you can A, prevent that, and then B, start treating it early, I think makes a huge difference in terms of range of motion, pain, and also normal sensation.
Yeah, no kidding. Can you speak a little bit about the early stages of scarring and
sure,
and how that?
So scar formation, it's sort of interesting. What happens is your body starts healing right away, and after the injury, there's a slurry of cells that get sent to the injury, and the slurry part is why you have swelling.
It's like a slurry, yeah.
And so there's literally liquid. And so there can be, serous fluid, which brings the cells there. And then there's also swelling in the tissue. And what they do is they start laying down collagen. And at first they're just putting down collagen. And so that's why it's really important to actually have enough protein in your diet.
Yeah, I was about to say, yeah.
People who are protein malnourished won't heal. And so people who are vegan, you have to make sure that you're getting a complete protein, because it can be a problem with wound healing. Yeah. But it gets laid down in a very disorganized fashion. It's just kind of it's like throwing cement to cover a hole. And then your body starts reorganizing it and kind of almost breaking it down a little bit into a construct that then gains strength. And by 6 weeks, it's as strong as it's going to be. And then it can start sort of quote unquote remodeling. Mm. So until there probably aren't things that you can do other than good, healthy diet, to interfere with that too much. Mm-hmm. But, if you get a wound infection, if you have a hematoma, which is bleeding, if you have too much pulling on the incision, it could break open, that kind of thing.
That's also more and more is being said about not icing after injuries, because you slow down that slurry. Just let that slurry get there. That swelling is the healing that's happening. And we all learned from 5th grade gym or something to ice our ankle immediately if you sprain yourself, but just actually letting that healing process happen and instead of inhibiting it.
Well, and I don't know the answer to this, but pain is a really interesting phenomenon, because pain tells you that there's a problem. So, in general, it's a very important feedback mechanism, right? So if you feel pain, if you think about leprosy, the problem in leprosy is the reason why people lose limbs is because they they stop feeling. And so they hurt themselves and they don't realize they've hurt themselves. And that's, that's where the problem lies.
Yeah.
So pain is a really important feedback mechanism, but sometimes it goes awry. And post-surgery is a place where it can go awry and people can get into bad feedback loops in terms of feeling pain, then trying to avoid pain, and then not getting back to normal sensation. And that's where like your work is so important in terms of fascial release and scar release, because that can get people back to normal sensation, right, and normal sort of tissue sensitivity.
It is really fascinating. I think it's hard for people to conceptualize this sort of how we have this kind of liquid body like under the surface, this sort of like gelling, coagulating body, and that our fascial structure literally kind of can be this kind of disorganized, like having all your jewelry chains bunched up in your jewelry box, and then it can organize and clear itself back out and be this kind of flexible structure again with space and kind of cellulose looking almost like a honeycomb or something. I mean, that is endlessly fascinating to me. I think it's really hard for people to recognize that is literally the sensation that you're feeling. If you're having inhibited range of motion, you're actually feeling this kind of bunched up, like the saran wrap around the cheese, just like all stuck to itself.
But the cool thing about it is, even if you had surgery 20 years ago and you have some impingement of range of motion, a lot of times it's never too late. I mean, you can work on that scar tissue and release it and get back your range of motion. And also cosmetically, you could improve, we tend to only think about the scars that were visible to us, but, when you have surgery, it's generally not just skin deep. I mean, generally it goes down, much deeper. And if you're going into bone or muscle or whatever. And the cool thing is a lot of times those deeper scars can be improved upon with, the work that you do and other kinds of physical therapy.
Absolutely. I have a number of clients that are in their 70s. And one of my clients actually came to me through her daughter. She's about 74, and they were worried that she might need a hip replacement. But so far we have been able to put it off because just doing some basic strength and mobility work, her hip is not hurting her anymore. But what's been really interesting is she told me that she really thinks her hip started hurting her because like 30 years ago, she really terribly sprained her ankle and had a little surgery to repair the tendons. And ever since then, it's been really tight. And she thinks that and she never really did any real rehab for it, blah, blah, blah. So we start working on that scarring. She's 74. We start working on the scarring on her ankle. And this is all virtual too. So she's working on it with her own hands with my direction. And she's like, oh my God, my ankle feels totally different. It changed the way her back feels. This is a 30-year-old scar on a woman who's very inactive. I mean, she's like this classic grandma who like knits all day. She's very cute, but like, she's not. I have some 70-year-olds that are like out power walking and they're super active. She really is like at home. And just when I get on the screen with her is when she moves around and we're making good progress. I mean, I think the body is really very inspiring. I always tell people, as long as you're alive, your cells can change. Our bodies want to be comfortable. They want to be efficient. If you're alive, we can make change.
100%. And I think those imbalances, if anything goes out of whack, then something else is you will compensate, but then there'll be another problem too.
Yeah. And that's part of that amazing kind of gel body that we have underneath. Yeah. It's always receiving information and shifting and changing like a tide kind of.
Totally.
I definitely want to talk about bottom surgery. Why don't we just touch on exactly what that surgery is? Because I just think, again, it's not out in the news much. And it's a surgery that a lot of people are getting.
Yeah. So, the language in all of, gender affirming care is changing. And so some of it, sort of becomes outdated. But historically, what we talked about was female to male bottom surgery or male to female bottom surgery. And so one is creating a vagina from, a penis, and one is creating a penis from a starting point of having a vagina. So obviously they're very, very different operations. Vaginoplasty is creating a vagina, and that is historically more kind of represented and was the first bottom surgery to happen. There's been a lot more research in that. It's now I would say it's a very successful operation with a pretty low complication rate. And it's, it was very like interesting surgery. So basically you take the parts that are there, so the penis, and you kind of imagine like invaginating that inside the body. I mean, literally. So you're taking something, you're debulking it, leaving all the sort of the skin part attached, leaving the stimulatory parts attached, and then creating this space inside the, really it's sort of in the abdominal cavity, but it's below that. Right. So,
right. Because the big difference is there's no birth canal. So you're
right. So there's no uterus, there's no, cervix, there's no ovaries. And so there's sort of two parts to it. One is debulking the penis, so it becomes just like the skin, and then removing the testicles, and that skin then is used to create a vagina, a vulva.
To sort of create labia.
To create labia, exactly. And then, but really you're trying to create also a potential space so that you could have penetrative sex.
Right.
So there's like the external part, which comes from the testes, or the testicles, which then, becomes the lips of the vagina. And then the internal part, which becomes the vaginal canal, which is the invagination of the penis. So it's kind of hard to visualize, but so there,
since
surgically,
the penis, it's a urethra. So are you then having penetrative sex essentially in a urethra?
No. So they shorten the urethra. So, if you think about where the vagina in the urethra in a female, the vagina then becomes, like a vaginal canal, but the urethra would be sort of at the top of that.
Okay.
Just like in a cis female.
Okay.
So the big thing about a big reason why vaginoplasty is successful is that you're shortening the urethra, and it is very hard to create a urethra from nothing. So
that makes sense.
So then the second part is then putting that sort of anchoring that invaginated penis inside the body so that you're creating this internal canal. And then the important thing about that surgery is post-op, there's a lot of care to keep that canal open, because the body just tends to want to like close stuff down. And so there's a whole protocol of dilation, of vaginal dilation. So as soon as it's healed, the women have to start sort of dilating that area to keep it open. And that is a daily practice, and it's, extremely important. I think in most cases it's not painful, but could be. Sure. And, we were talking about scar tissue, the body wants to make scar tissue, any place it heals. Yeah. And then in terms of phalloplasty, there are many different ways of actually creating a penis. And one is just using the parts that are there. So for a lot of, trans masc folks who are on testosterone, their clitoris will enlarge. And sometimes it'll enlarge so much, it really kind of, resembles a penis. So there's a way of releasing some ligaments and lengthening that clitoris it's called a metoidoplasty. So you're not adding any more tissue. You're really just using what is there and releasing it so that it hangs in a more sort of masculine way. And for a lot of people, people have different goals in terms of why they want a phalloplasty. And so part of the interview is like, what are your goals? And for many, it's to just to be able to stand and urinate. And for others, it's to have penetrative sex. So metoidoplasty probably wouldn't achieve penetrative sex in most people. So then there are phalloplasty techniques where you're literally creating a phallus from tissue in other parts of the body. And the most common parts are the forearm and the thigh. And then there are other places that have been used, but those are probably the most typical these days. And you are basically creating a tube, and then you are trying to create a urethra. And that's tricky because the tissue of the urethra is very specific, and it's really hard to recreate that tissue. And so if you think of a typical cis female's urethra, it's very short compared to the urethra. A penis could be very long, could be 6 inches, 7 inches, whatever. So that can be the really tricky part. And then it's always staged because, so now let's just say you've accomplished that by creating this sort of tube, and you've figured out how to make the urethra. There are different tissues that we use for that, sometimes skin, sometimes intestine, even the inside of the lining of the mouth. And then you want to figure out, how do you make that firm so that you could have sex, penetrative sex. So often an implant needs to be inserted to make it hard. And then some people choose to get testicles also reconstructed. So there's a lot of steps. And
is the implant some sort of like...
It's a foreign body typically. So it's similar to what cis men get if they, either have cancer or have some sort of erectile dysfunction. And it's basically like a little balloon that is connected to a rod that's usually silicone or some sort of plastic material. And you can literally pump up
using an external device of some kind.
Or your hand. Oh, and it sort of fills it up. And amazing. I mean, it's pretty cool, but it works. And then sometimes, depending on, there are some muscle reconstructions where if the muscle can get tense, then it's firm enough that you could have penetrative sex.
Wow.
So it's super complicated, and generally is at least 2 stages. But could even be more. Whereas vaginoplasty, I mean, it is complicated, but it is, it's simpler to take away than to create.
Yeah. I have a friend that just did vaginoplasty and is doing the dilation and everything. And I think it's important for people who have not experienced any of this. Most people going into this have probably been on hormones for a long time, correct?
Yeah. I think the requirement is 2 years. But it could be longer than that, certainly, but definitely 2 years.
That's also going to change someone's genitals because from what I understand, if you're becoming trans female, your penis at that point is very small. And vice versa.
That's
like
right.
You said, the clitoris can grow quite a bit.
Yeah. So it can definitely shrink that, and the other way it can grow it.
Mm-hmm. That's fascinating. I mean, I just did a post to just reiterate that we're all female in the womb, And then I think it's about 9 weeks, if you're going to be male, that gene starts to express. And then your ovaries go on a little journey and they turn into testicles. And basically, the clitoris and the urethra become one tube. But I feel like people don't realize that the female form is the OG form, basically, and everything is coming from that. And that's
Isn't
also
that fitting.
Yeah. And so really all of our tissue is very similar. And if
it is,
it's
very, very similar. Yeah.
If you are heterosexual and you are a female, if you look at your male partner's testicles close up, that skin is labial skin. I mean, that's what it looks like.
Totally.
It just gets beaten up a bit more because it's not internal. it's
right.
And it's the same stuff.
Embryologically, we're all, the same. And then things just sort of take a divergent path, and become expressed, differently. And I think,
it also means that, clitoral tissue and the skin of the penis are basically the same. That sensitivity. I feel like it's important for women to understand that, which is also like a low key argument against doing circumcision, because it's very, very sensitive tissue and it's covered for a reason, because it's like a long clitoris, like a giant clitoris.
That's really true.
And when you take that skin off, it loses quite a bit of sensitivity, from what I understand.
Yep.
But what were you going to say?
That one, there's sort of an interesting. Well, I don't know if there's a movement about people who are born with both genitalia.
Right.
And, it historically has been something that parents and doctors decided at the time of the birth often, and would, eliminate one genitalia. And it really, it's not surprising, that's the wrong decision. And the right decision is to, allow the child to decide for themselves what gender they're connected to. And they will know, and they will figure it out at some age. And then, a decision could be made about whether to do anything or nothing.
Yeah.
And I definitely have patients who have fallen into that category. And I just think, it's just interesting these days. There's a lot of talk about minors getting surgery or minors having puberty blockers. And there's a big political kind of agenda against that. And it's a really very small group of people who are seeking that kind of surgery or hormones. So it's interesting. There's such a big uproar about it, because it really is, tiny numbers. But I think what is also interesting is that those same people don't seem to be particularly upset that, these children are having surgical decisions made when they're infants.
Right.
And talk about, having no rights. I mean, that clearly is not appropriate.
Yeah, no kidding. And from what you're saying, it sounds to me like they probably make the decision to make them female more often than not, because it's easier to get rid of.
It's easier. Exactly. Yeah. That's exactly right. And that, if there is a movement, about that now, which is good, because I think, to have enforce surgery on folks who have no voice, literally like babies. It's really sort of appalling. That's
fascinating.
Plug.
No, that's fascinating. And I think people don't realize, first of all, that we're all female in the womb. And so this is basically my argument that gender is a construct, because we all start as one gender. Another one just sort of expresses from that original one. And because it goes on this little journey, because the testicles kind of the testes go on a little journey from being ovaries dropping down. That's how you end up sometimes with men who don't have testicles that have fully dropped, or very, like a very right, or a very small penis because it's basically a clitoris that hasn't fully become a penis. Like all these things, and there's so much kind of taboo around all these issues, but really it's because we're deciding that men are supposed to have this big giant package and all these things. And it's like, we're just making, I mean, that's why I was like, what's a non-binary nipple? Like, I was just like, it's fascinating that it's really true that this is how we signal what our gender is. Look at my low, wide nipples. Now I'm a man, like it's amazing.
Right. Yeah. It's definitely,
actually, my boyfriend, we were talking about being like awkward tween years or whatever. And he was like, I always joke that he was a cool kid and I was a nerd when we were in school. And he was like, no, I wasn't. I got made fun of. And he was like, I had terrible skin. And then there was a moment where I had little girl boobs for a while. And I was like, what do you mean? And he was like, my nipples were all big and puffy like a girl's in the beginning of puberty. And now, now, when you were describing male nipple, I was like, those were like tiny, flat, he was like, he went through that awkward stage and had like little boobies. And I was like, oh, it's so hard. It's so hard.
God, I mean, I wouldn't go back to being a teenager for nothing.
Never.
Oh my God. I mean, everything was so embarrassing. Like everything is so embarrassing. Aren't embarrassing or were embarrassing. I would never
go back to developing breasts again. My God, I remember it was so painful and strange.
I know.
So, but yeah, we are all one, as it turns out.
Well, it turns out it's true. And it really, I mean, I think I hope that our society can evolve to the point where there isn't like politicization about this. I mean, I think our gender expression is just, it's so individual and so insignificant for anybody else. I mean, I don't know why anyone other than yourself cares about your own gender expression.
Exactly.
And I do find it fascinating that they're so threatening. But I think, it makes sense that once, a long time ago, it was important that, there were men and women to keep the species going. But, now we've got assisted reproduction and lots of things. So like, we don't, and
we're destroying the planet. We all need to be churning out more babies.
And then there's that. So I think it's, just, I don't know why it's so threatening because it's not like it's just,
well, people have such a narrow definition of themselves and then someone else who doesn't. And then you come to pieces with it because you've never even considered another way of being.
Right.
So, but thank you so much. This is fascinating. We've been wanting to have this conversation for a while and
forever.
I get some questions and some feedback. I'd love to do it again.
Yeah, absolutely. We'll be in touch. After our last podcast I wrote a blog about Fascia Release.
Oh yeah.
And it's like the most popular blog I've ever written.
It's a hot topic these days.
It is a hot topic. It's awesome. Well, it's so great to see you. And thank you so much.
Thank you.
And we'll be in touch, okay?
We'll be in touch, yeah. Thank you so much.
Okay. Bye.
Bye.